अभी टीचर्स नहीं है। वो किधर मैंने भूत नहीं ऑन कर रखा था, तेरी गाली चली गई है।
Good morning, everyone. Today our topic is metabolic bone diseases. So, what are the metabolic bone diseases? So, it actually encompasses a diverse group of disorders associated with altered calcium and phosphorus homeostasis. I will call it MBD. The MBD is often silent until the patient presents with fracture. So what are the different kind of MBDs? Osteoporosis, osteomalacia, and rickets, and hyperparathyroidism. First, we will talk about osteoporosis. So the most common metabolic bone disease, one of the most prevalent condition associated with aging. So here you can see how it reduces bone mass of the normal composition. Here you are seeing a normal bone as well as an osteoporotic bone. And you can see the bone mass is reduced in this thing. So in clinical definition, osteoporosis requires presence of a non-traumatic fracture, but in histologic definition, it requires reduced quantity of mineralized bone. So there is a difference between these two definitions. In clinical definition, there should be a non-traumatic fracture. And histologic definition, it shows that there is decreased quantity of mineralized bone. Here you can see the classification. This is the T-score. Usually in normal bones, T-score is usually between 0 to -1. Okay. And in osteopenic bone, it is between -1 to -2.5. And in osteoporosis, it is less than 2.5. And in severe osteoporosis, less than 2.5 plus a fragility fracture. So the about classification of this thing. So the primary osteoporosis is like postmenopausal osteoporosis, that is called type 1. That is because of lack of estrogen, and it causes parathyroid hormone to overstimulate osteoclasts, and it causes excessive loss of trabecular bone. Because estrogen is less, parathyroid will increase osteoclasts and excessive loss of trabecular bone will be there. And the other one is age-associated osteoporosis, that is called type 2, where bone loss due to decreased bone turnover, malabsorption, and mineral and vitamin deficiency. And now we will talk about secondary osteoporosis that can be hormonal, like hyperparathyroidism, hypoparathyroidism, hypogonadism, pituitary tumors, DM type 1, Addison's disease, and Cushing syndrome. The second one is nutritional, like vitamin D deficiency, calcium deficiency, and the third one is the drugs like corticosteroids, alcohol, anticonvulsants, and vitamin D toxicity as well. Inherited metabolic disorders like Ehlers-Danlos syndrome, osteogenesis imperfecta, and Marfan syndrome, these are also secondary causes of osteoporosis. And fifth is other causes like porphyrinuria, myeloma, thalassemia, pregnancy, anorexia nervosa, and seismic mastocytosis. Here you can see this is called the concept of peak adult bone mass. In between the age of 15 to 20 years and up to 40 years, here you can see the bone mass is maximum in total lifespan of a person, and it usually about approximately age of 20-25. This is at its peak level. Both women and men are looking similar in this graph. And after the age of 40 years, you can see both the men as well as women are going into osteopenia, but bone mass is decreased abruptly in women's graph in comparison to men's graph. So here we can say that estrogen deficiency can cause this thing after menopause. You can compare these two things, that women's graph is going abruptly down in comparison of men's graph. So now we'll talk about etiology and pathogenesis. So the genetic factors. The prevalence varies according to race due to difference in peak bone mass. Adult blacks bone mass is usually more than whites and Asians. Estrogen status. Estrogen inhibits osteoclast and stimulates osteoblasts. It causes activation of new bone remodeling sites and exaggerates imbalance between bone formation and resorption. Some endocrine disorder like hypogonadism that causes bone loss in both men as well as women, and other endocrine disorder like hypogonadism disorder like panhypopituitarism, Klinefelter syndrome, these also causes the same thing. Hypercortisolism like Cushing syndrome in chronic steroid therapy, it leads to decreased intestinal absorption of calcium and also stimulates parathyroid vitamin D endocrine axis, leading to bone resorption. Here you can see the hyperthyroidism and hyperparathyroidism, how they increases bone turnover and remodeling causes a net increase in bone resorption. They are increasing bone resorption. In this way, they are increasing calcium amount in the serum, but it is decreasing the BMD of the bone. Some kind like nutritional deficiency, they can also cause the same thing, like adequate calcium intake is vital for maintaining peak bone mass. In response to calcium deficiency, the body robs the calcium it needs from skeletal reserve by increasing parathyroid hormone and 1,25-dihydroxy vitamin D2. Vitamin D, it's a dietary source supply only 50% of the vitamin D. The remaining is synthesized in the skin in response to ultraviolet irradiation. The active form of vitamin D helps maintain normal levels of calcium and phosphate. And the other things like drugs, alcohol, and smoking, they also causes the same thing. Like chronic alcoholism is the most common cause of bone loss in young men, in part because of poor nutrition and tobacco smoking, as well as the drugs like corticosteroid, alcohol, anticonvulsants. Cytotoxic drugs, lithium, are also associated with the increased risk of osteoporosis. Other things like chronic illness and tumors, they also leads to osteopenia, like malnutrition and other things like myeloma. Myeloma cells actually produces cytokines that potentially stimulates bone resorption, as well as some neoplastic disease appears to cause osteoporosis through osteoclast activating factors like interleukins and tumor necrosis factors. And the other one is disuse atrophy. Disuse osteoporosis is more likely to develop in sedentary persons. It is not the lack of movement that leads to osteoporosis, but the absence of mechanical stress on the bone from weight-bearing activity and from powerful anti-gravity muscles. This leads to a progressive thinning and eventual loss of trabeculae. The loss of trabeculae is most dramatic in axial skeleton, especially the vertebral body. So here you can see disuse, like in a fractured patient, a patient who is having fracture of some extremity or spinal cord or some spinal vertebrae, they can also they can be also affected with the same osteoporosis because of the lack of the movement of the anti-gravity muscles as well as weight-bearing activity of the body. So what are the clinical manifestation? It is actually a silent thief, usually remains asymptomatic until the weakened bone fractures. Complications are compression fracture of the vertebral body and fractures of hip, ribs, humerus, and distal radius. Osteoporotic fracture are suspected in elderly people. Sudden onset of pain, stooped posture, shortened stature, and fractures of hip with minimal trauma. So after a trivial fall, if someone comes with a fracture of the hip, you should always suspect a osteoporotic fracture in elderly people. And what are the manifestation in vertebrae? So the earliest symptom of osteoporosis is often an episode of acute back pain. Spine movement is severely reduced with flexion reduced more than extension. Pain intensifies with sitting or standing and is relieved on rest. Coughing, sneezing, and straining to move the bowels can exacerbate the pain, and anterior compression fracture may cause thoracic kyphosis. Stooping posture is characteristic of osteoporosis. The spasm of paravertebral muscles are palpable and often visible in these patients, and spontaneous vertebral compression fracture are stable injuries in these kind of patients. So what are the diagnosis modalities? So first is bone densitometry. This is called gold standard for this thing. So it can detect osteoporosis before fractures, it can determine severity, and it can estimate risk of fracture as well. So serial BMD measurements enable determination of rate of bone loss or gain, and therapy help in monitoring therapy. And in plain film, loss of 30 to 50% of bone is required before it is detected on a conventional radiograph. So you can see the difference between these two, that by bone densitometry, we can get an idea much before than a plain radiograph film. Here you can see how they gives the report of the bone mineral density. They usually see neck of the hip as well as the vertebrae, usually to see the bone mineral density of a patient. And AIIMS Z score, you have to see how it is different between the different sides of a patient's body. So you can get an idea if somebody is suffering from osteoporosis or not. What are the radiological findings? The most common radiological finding is generalized osteopenia, the cortical thinning and accentuation of the weight-bearing trabeculae. First thing is cortical thinning, and the second thing is attenuation of the weight-bearing trabeculae, and the bone surfaces are well defined with sharp margins. Other thing is fractures. Vertebral deformities, which are also common, include biconcave end plate fish vertebrae. They are called fish vertebrae, and anterior wedging. Here you can see biconcave as well as this is a lateral radiograph of a lumbar spine, which is showing a generalized osteopenia as well as compression fracture. Here you can see compression fracture in the anterior aspect of this thing, and biconcave vertebral end plates as well. This picture is more clear to see how it looks like in a osteoporotic vertebrae. Here you can see compression fracture as well as biconcave vertebrae. Vertebrae looks like this when we are seeing it from above. About to done. Radiological findings. Third is the patient with osteoporosis secondary to excess steroids. They can cause generalized osteopenia, fracture exuberant callus, and steroid-related complications like AVN and osteomyelitis. And for the osteopenia, differentials can be like osteomalacia. Osteomalacia is indistinct trabecular and poorly defined interfaces between cortical and trabecular bones and presence of looser zone. I will show you after some time what are these. The other thing is hyperparathyroidism can also show the same characteristics as well as in multiple myeloma. In multiple myeloma, MR imaging may show areas of marrow replacement as well. Regional or localized osteoporosis. This can be due to immobilization and disuse. This is on, we are talking about only localized osteoporosis that can be due to the immobilization and disuse, as well as reflex sympathetic dystrophy syndrome, and transient regional osteoporosis like transient osteoporosis of the hip, regional migratory osteoporosis that can be seen in the inflammatory arthritis, tumors, and infections. So what is RSDS? It is actually mediated by the sympathetic nervous system and is characterized by aggressive osteoporosis, soft tissue swelling, and usually the cause is traumatic, but the disease may also be idiopathic as well. So here you can see a radiograph of a patient who may be who is suffering from a distal radius fracture in right side, and in left side you can differentiate the cortical density as well as the bone mineralization in both of these hands. In right side, you are seeing that there is less BMD in comparison to the left one. So this is actually an example of Sudex dystrophy. Assessment of osteoporosis. So first of all, radiographic bone densitometry. So the spine, grading systems for spine is based on the appearance and thickness of cortical shell. Vertices are graded from 6 to 1 as the vertical trabeculae pattern becomes more pronounced with the loss of horizontal trabeculae and the cortical shell becomes progressively thinned. Here you can see thinned cortical shell. There is small lines which are showing like cortical shell is become very thinned. As well as you can see that horizontal trabeculae are not seen in this X-ray, but the vertical are looking good. And there is one Singh index as well, which is usually used to define osteoporosis in a femur. So it divides a femur, or we can say a hip X-ray AP view into 6 grades. So grade 6, which shows all normal trabeculae. Here the first one picture on left side, which is showing grade 6, and in grade 5 the principal tensile and compressive trabeculae are attenuated. Both the principal tensile as well as compressive trabeculae are attenuated. The second picture from left side, upper row. And in grade 4, equivocal evidence with principal tensile trabeculae reduced. And in grade 3, definitive osteoporosis, break in continuity of the principal tensile trabeculae. Here you can see the tensile trabeculae, which is broken. In grade 2, marked osteoporosis. Here you cannot see any of tensile trabeculae. The second picture from left side, in second row, here you can see no tensile trabeculae is seen, only compressive trabeculae is seen. And in grade 1, severe osteoporosis, there is marked reduction even in the number of principal compressive trabeculae as well. So there is no tensile as well as very little you can see the compressive trabeculae. So what are the other modalities like quantitative computed tomography? This is usually used to measure the spine and provide separate measurements of the cortical and trabecular bone, and may be especially valuable in older people. And in ultrasound, it is used to measure bone mass by calculating the attenuation of the signal as it passes through the bone or through the speed with which it traverses. Mainly used in screening because of low cost and mobility. What are the markers for osteoporosis? So first we have to see what are the markers of bone formation, like serum alkaline phosphatase, serum osteocalcin, and serum CN propeptide of type 1 collagen. These all three are marker of bone formation. And what are the marker of bone desorption, like urinary excretion of pyridinium, as well as urinary excretion of C and N-telopeptides of collagen, urinary excretion of galactosyl, hydroxyproline, and urinary excretion of hydroxyproline, and serum tartrate resistant acid phosphatase. These all are markers of bone desorption. So how we can prevent osteoporosis? The osteoporosis is not an inevitable part of the aging process. It can be prevented as well. So the increased bone mass by exercise, nutrition during adolescence to achieve peak bone mass, and also at any age to maintain bone mass. Drugs at menopause. Women needs drug therapy twice in her life, once at perimenopausal and second time in old age. Yearly BMD measurement, especially in females. No excessive use of alcohol, no smoking, good exercise like aerobic, muscle strengthening, and balanced nutrition that can help us to prevent osteoporosis. Nutritional recommendation, if you can see here, here I am showing you calcium milligram per day requirements. So between age 1 to 3 years, 500 milligram per day is required, And in age 19 to 50 years, it's 1000 milligram per day. And age more than 51 years, it is required 1200 milligram per day. And as well as the dairy products, green leafy vegetables, juice, cereals are good source, but most patient require supplements and it should be taken in dose of greater than 600 milligram at a time, as calcium absorption fraction decreases at higher dose. Vitamin D. Even though it is called a vitamin, vitamin D acts more like a hormone that it helps to increase calcium absorption and decreases calcium excretion. So the vitamin D can be synthesized in the skin when the skin is exposed to ultraviolet B rays from sunlight. A 5 to 10 minutes exposure of sunlight to the unprotected arms and legs results in the production of 3000 international unit of vitamin D. Proper intake of calcium and vitamin D may decrease fracture rates by up to 25% by maintaining good bone health. Over the past several years, the recommended daily dose of vitamin D has increased. The newest recommendation suggests that 1000 international unit of vitamin D is needed daily. Other factors which are essential like adequate vitamin K as well as adequate protein and caloric supplementation as well as exercise in young individuals, they all are helpful to prevent osteoporosis. And what are the medical treatments like hormonal replacement therapy, estrogen? So estrogen, what it usually does, it reduces turnover, prevents bone loss and induces small increase in bone mass. And dose for oral route of this estrogen is esterified estrogen is usually used 0.3 milligram per day. Conjugated equine estrogen is used 0.6 to 5 milligram per day. And ethinyl estradiol is 5 microgram per day. And by transdermal route, 50 microgram estradiol per day is required. And progestins, in a woman with a uterus intact, daily progestin or cyclical progestin at least 12 days per month are prescribed in combination with estrogen to reduce risk of uterine cancer. HRT should be started early within 5 years of menopause, as loss of estrogen at menopause triggers a period of rapid bone loss of about 5 years. Selective estrogen receptor modulators, these are also good for prevention of osteoporosis. And the raloxifene is a devoid of action on endometrium and being extensively used for prevention of osteoporosis and breast cancer. And 60 to 120 milligram per day increases the BMD. And it also reduces the occurrence of vertebral fracture by 30 to 50%. And bisphosphonates. This group of drugs are currently the most potent treatment of osteoporosis based on BMD and fracture studies. They actually inhibits bone resorption by preventing protein prenylation in osteoclast owing to inhibition of farnesyl diphosphate synthetase. Here you can see binding affinity of bisphosphonates and you can see the structure and relative potency. So zoledronate having relative potency of 1000 and it is used once a year, 5 milligram once a year. Abandronate is having relative potency 500 and alendronate is 100. So what are the indications of bisphosphonates? Like osteoporosis, postmenopausal women, avascular necrosis of hip, as well as Perthes disease, joint cell tumor of bone, total hip replacement to prevent loosening. And what are the complications? Like subtrochanteric fracture, that is called atypical fracture after prolonged use of bisphosphonate, more than 5 years. So you should having a window period between after starting this bisphosphonate, you should stop after 3 to 4 years to decrease these subtrochanteric fracture which are caused by a long bisphosphonate therapy. Avascular necrosis of mandible is also a complication of this thing. And what are the FDA approved doses of bisphosphonates are? So alendronate, if you are giving as a preventive dose, so you should give 35 milligram orally weekly. Or if it's a treatment for osteoporosis, then it should be given 70 milligram orally weekly. In this way, ibandronate you should give 150 milligram orally monthly for prevention of osteoporosis, but for the treatment you should give 3 milligram IV every 3 months. And the zoledronic acid you should give 5 milligram IV yearly. And risdronate for prevention and treatment 35 milligram orally weekly and 5 milligram orally daily, you can also say this thing, and 75 milligram per oral every 2 consecutive days monthly for the osteoporosis therapy. Other things which are used like calcitonin spray, this can be also given. This is actually a subcutaneous injection or a nasal spray. And each nasal spray contains calcitonin 200 international unit per day, and it is approved to treatment therapy in osteoporosis in postmenopausal women, and most valid indication is intractable pain caused by vertebral fracture. So if someone comes to you with a vertebral fracture with intractable pain, you should start her on some calcitonin nasal spray, or you can start her on subcutaneous injection as well. As well as parathyroid hormone is also associated with maintenance of trabecular bone mass, and it is approved for treatment of osteoporosis in patients with high risk of fractures. Now we will talk about rickets and osteomalacia. Rickets and osteomalacia are similar histologically. So what happens actually, the abnormality in vitamin D metabolism and incomplete mineralization of normal osteoid tissue. Again, I am saying it's an incomplete mineralization of normal osteoid tissue. So rickets occurs in children, affects immature bone, and osteomalacia occurs in adults, affects mature bone. This is the homeostasis cycle in our body, which usually disrupted in these conditions like vitamin D deficiency, malabsorption, chronic liver diseases, and renal osteodystrophy. These three can cause decrease maintenance of calcium and phosphorus homeostasis. In this cycle, you can see the A portion, which is due to the vitamin D deficiency or malabsorption, B is due to the liver disease, and C is due to the kidney problems. Clinical findings of rickets and osteomalacia. So depends in part on the etiology and severity of the disorder as well as the age of the patient at presentation. So in rickets, stunted skeletal growth, apathetic, irritable, hypokinetic, frontal boozing, softening of the skull, dental caries, rachitic rosary, kyphosis, joint enlargement, bowing of long bones, fractures, and SCFE, slip capital femoral epiphysis in children. These are the children which are showing rickets problem in all these children. You can see the bowing of legs, rachitic rosary, stunted growth. Here you can see a picture of a small infant which is showing a rachitic rosary. And osteomalacia, that is more subtle, like fatigue, malaise, or bone pain. These are the common symptoms. Proximal muscle weakness and abnormal gait may also be present. The radiological finding of osteomalacia are often non-specific, difficult to confirm the diagnosis with imaging studies only. The most common radiological sign is generalized osteopenia, coarsened and indistinct bony trabeculae, poorly defined interfaces between cortical and trabecular bone, loser's zone, or that is called pseudo fractures. These are more specific, but these are very less common. And end plate deformities and fractures of the vertebral bodies, bowing and fracture of the long bones, and basilar invagination of the skull. What are the loser zone? So these are linear area of undermined mineralized osteoid that occur in a bilateral and symmetric distribution. What are the characteristic sites are? These are femoral neck, proximal ulna, axillary margin of the scapula, pubic rami, and ribs. And what are the differentials are Paget's disease or fibrous dysplasia. This is a AP radiograph, a 50-year-old man, osteomalacia showing portion trabecular pattern with indistinct trabeculae. Here you cannot see a trabeculae very well. Here you can see the trabeculae, but distal portion you cannot appreciate this trabeculae. And this is a AP radiograph of patient which is showing osteomalacia and multiple loser zone in superior pubic ramus. Actually, this picture is not very clear, which is showing pseudo fracture of the bilateral femoral neck. And for rickets, most common radiological sign is generalized osteopenia, increased lucency, widening, elongation, irregularity, and cupping of the metaphyses. Earliest are slight axial widening of the physis, and next is increased lucency of the zone of provisional calcification. And the more advanced is the physis widens and its contour becomes irregular. Occasionally in patients with rickets caused by chronic renal disease, increased sclerosis may also be seen. The reasons of highest yield on radiographic evaluation of rickets are those that are undergoing rapid growth, like costochondral junction of middle ribs, distal femur, both ends of the tibia, distal radius and ulna, and proximal humerus. The complication of rickets, like skeletal deformities in neonates, posterior flattening and squaring of the skull or craniotabes may also be seen. In early childhood, bowing deformities of arms and legs are common. In older children, scoliosis, vertebral end plate deformities, basilar invagination of the skull may also be seen. And in advanced disease, slipped capital femoral epiphysis. These are the 10 important clinical features in pictures. Picture is showing 10 important clinical features in rickets, like delayed closure of fontanelles, frontal boozing, dental hypoplasia, pectus carinatum, swelling in wrist and ankle joints, wide sutures, craniotabs, rachitic rosary, Harrison sulcus, and bowing of legs. This is a AP radiograph of a 2-year-old girl, where you can see the generalized osteopenia as well as widening of the metaphysis, which is usually we can see in rickets. Here you can see the widening of the epiphysis at the joint distal end of radius. You can appreciate this very well. Here you can see the fraying at its edges and cupping in the main shaft region of the bone. You can see the cupping and fraying at the margins of the bone. So in these patients, what should we treat? So when should we treat? So if the serum 25-hydroxy level is less than 30 nanomole per liter, treatment is recommended. If it's 30 to 50 nanomole per liter, treatment is advised in patients with the following things, like fragility fractures or vitamin D deficiency symptoms like malaise. Treatment with anti-resorptive medications for bone diseases. If someone is on anti-resorptive medications, and if the patient is having increased risk of developing vitamin D deficiency in future because of reduced exposure to sunlight, due to any religious or cultural dress code or dark skin, like these things, here we should treat. And if the serum 25-hydroxy level is greater than 50 nanomole per liter, so provide reassurance and give advice on maintaining adequate vitamin D levels through safe sunlight exposure and diet. What are the doses? So these are the following are the recommendation to treat vitamin D deficiency. So if someone is having less than 20 nanogram per ml vitamin D, so you should start him on dose 50,000 international unit per week for 8 weeks. And after continuing treatment for 8 weeks, continue it for another 8 weeks. And then you should retest if it's less than 20 nanogram per ml. And if it is greater than 20 nanogram per ml, the amount of vitamin D needed to maintain optimal levels is usually 800 to 2000 international unit per day. So you have to repeat the vitamin D level at 12 weeks. Now we will talk about hyperparathyroidism. So this can be due to primary causes as well as the secondary causes. The primary causes are parathyroid adenoma and the secondary causes are chronic renal insufficiency. So hyperparathyroidism may result in either bone resorption or bone formation. Bone resorption usually dominates. This is actually a normal cycle, how it affects parathyroid, how it regulates calcium and phosphorus in body. So you can see the dietary calcium and phosphate which are absorbed from the intestine, and parathyroid hormone regulates serum calcium. So it really, if body's demand is increasing or there is less calcium in the serum, then it increases parathyroid hormone from the gland, and it increases the calcium level in serum. And phosphate resorption is decreased in kidneys as well. So what usually it does, it increases calcium absorption and decreases phosphate reabsorption from kidneys. So the most common radiologic abnormality is generalized osteopenia. Other thing is bone resorption, bone sclerosis, brown tumors, chondrocalcinosis, soft tissue calcification, and vascular calcification. Brown tumors, what are they? They appear as well-defined lytic lesions. After resection of parathyroid adenomas, the lesions may become sclerotic and may mimic blastic metastasis. Bone resorption, the most characteristic finding is usually classified as subchondral, trabecular, endosteal, intracortical, subperiosteal, subligamentous, and subtendinous. Here you can see subperiosteal resorption first, which is most common. It usually occurs in the hands and feet. Most common affected sites are radial aspects of the middle phalanges. Acroosteolysis or phalangeal tufts resorption may also be present. Here you can see the radial aspect of the phalanges are absorbed, as well as the acrolysis. You can see the distal margin of the distal phalanx is also resolved. These all are features of hyperparathyroidism. Trabecular resorption, often seen in the diploic space of the skull, where it has a characteristic salt and pepper appearance. And subchondral resorption may be seen in the sacroiliac joint, sternoclavicular joint, acromioclavicular joint, symphysis pubis, and discovertebral junction. This is an epiradiograph of knee in a child with hyperparathyroidism, which is showing subperiosteal bone resorption. You can appreciate it at the arrow, black arrow. Salt pepper appearance of the skull. And this is actually a dental radiograph, which is showing resorption of the lamina dura of the mandible. Here you can appreciate the resorption of the lamina. So what are the radiological findings of hyperparathyroidism? So primary chondrocalcinosis, usually seen in the menisci of the knee, the triangular fibrocartilage of the wrist, and the pubic symphysis. These three are very important. And secondarily, we can see bony sclerosis, focal or generalized, rugged xerces, appearance of spine, and soft tissue and vascular calcification. Here you can see the TFCC unit, which is looking sclerosed. You can appreciate it in a AP radiograph. Here you can see the arrow, which is showing chondrocalcinosis of a triangular fibrocartilage. Here you can also appreciate this thing. Here you can also chondrocalcinosis you can also appreciate in this X-ray as well. Meniscal chondrocalcinosis. These are actually all soft tissue related complications. And here you can see that this AP radiograph of bilateral hip is not looking very normal. Chondrocalcinosis of pubic symphysis you can appreciate in this picture, as well as the sclerosis of the all bones, secondary due to hyperparathyroidism. This is actually a rugged xerces spine. Why we say this is rugged xerces? Because you can compare it with a rugged xerces. You can see sclerotic line, then osteopenic line, then again sclerotic line. It visualizes like a rugged xerces. As I have already told you, that AP radiograph of hand, which is showing acryosteolysis of the distal phalanges, and as well as the subperiosteal bone resorption over the radial aspect. And here you can also appreciate vascular calcification. These are small vessels which are calcified. You can see small lines which are calcified. And this is the radiograph of hand showing resorption of the first to third tufts with soft tissue calcification. There is articular calcification as well as subperiosteal and subligamental resorption as well. What are the differential diagnoses of hyperparathyroidism? So focal subperiosteal resorption involving a single bone like neoplasm or osteomyelitis, bone sclerosis in patients with secondary hyperparathyroidism like metastatic bone disease, radiation-induced bone disease, hypoparathyroidism, myelofibrosis, mastocytosis, sickle cell disease, and Paget's disease, chondrocalcinosis, pyrophosphate arthropathy or hemochromatosis, Brown's tumor like focal-lytic lesions, as well as giant cell tumor and fibrous dysplasia. What is the treatment strategy for this? So management of acute hypercalcemia by rehydration with normal saline, bisphosphonates, and hemodialysis. Medical line treatment is monitor serum creatinine level and calcium level every 6 months. DEXA scan on an annual basis. Avoid thiazide diuretics. Maintain high oral fluid intake. Improve bone mineral density and achieve calcium homeostasis by calcium mimetics and HRT. Surgery, it is indicated in patients with complications and in younger age groups. Minimally invasive surgery to excise solitary adenoma. Subtotal parathyroidectomy in case of diffuse hyperplasia can also be done. Now we will talk about secondary hyperparathyroidism. It occurs when the parathyroid hormone secretion is increased due to compensation for prolonged hypocalcemia. It is seen in patients with chronic renal failure where the failing kidneys do not convert vitamin D to its active form and they do not excrete phosphate. Excess phosphate combines with calcium to form calcium phosphate. Both processes lead to hypocalcemia, causes hyperplasia of all parathyroid tissue, and hence secondary hyperparathyroidism. So secondary hyperparathyroidism mainly due to chronic kidney disease, which due to the inability to decrease serum phosphate level in body, as well as inability to produce vitamin 125 dihydroxy D3. These two both abnormalities due to the kidneys, the parathyroid hormone usually increases to compensate the decreased calcium or deficiency of calcium in serum. It increases parathyroid hormone level. So the secondary hyperparathyroidism can also result from malabsorption of the vitamin D due to chronic pancreatitis, small bowel disease, or bariatric surgery as well. So these all three or all reasons for secondary hyperparathyroidism are usually associated with some chronic disease like chronic pancreatitis or small bowel disease where absorption is affected, or kidney disease. Clinical features are mostly of renal failure. If it is due to vitamin D deficiency, limb deformities, pathological fracture can also be seen. What are the investigation? So the serum calcium level are low in this. Parathyroid hormone levels are raised. Phosphate levels depend on etiology. So the high in renal disease, low in vitamin D deficiency. So these are very important actually, because in here in secondary hyperparathyroidism, serum calcium level are low and parathyroid level are high. And treatment, medical line is the mainstay. The undergoing condition needs to be treated with correcting vitamin D deficiency, treatment of chronic kidney disease like calcium supplementation, treatment with vitamin D and with its analogs, which is called calcium mimetics. Now we will talk about tertiary hyperparathyroidism. So what is this? In a small proportion of cases of secondary hyperparathyroidism, continuous stimulation of the parathyroids results in adenoma formation and unregulated parathyroid hormone secretion. So this is actually in secondary type of hyperparathyroidism, where it actually forms a adenoma in glands. Even correction of the underlying cause will not stop excess parathyroid secretion. Like parathyroid gland hypertrophy becomes irreversible. Even if we are correcting the underlying cause like kidney disease or like bowel disease, we cannot decrease the parathyroid secretion because of due to the hypertrophy of these parathyroid glands. What are the clinical features? In this, symptoms and signs are due to the hypercalcemia, so presentation is similar to primary hyperparathyroidism. Okay. Investigations, we should get serum calcium and parathyroid hormone levels, which are usually raised. Phosphate levels are usually high. Treatment, what should be the treatment? So total or subtotal parathyroidectomy is the recommended treatment. Autotransplantation of parathyroid tissue in the forearm is also commonly carried out. These two are treatment modalities which are recommended, and the most usually preferred is subtotal parathyroidectomy. So this is all about primary, secondary and tertiary hyperparathyroidism, as well as rickets and other metabolic diseases. If you are having any question, let me know. थैंक यू कर दोगे?
बस सर।